Hello people, this is Dr. Muskaan this side, and today I am going to discuss very beautiful case, and let me take you towards journey of this case. Here is 50-year-old male who has came to ER with chief complaints of vomiting and hiccups since 15 days. On arrival, ABCS was done, airway was patent, on breathing assessment respiratory rate was 24 per minute. That means patient was tachypneic because normal respiratory rate lies between 12 to 18 per minute. Patient was having desaturation, so 15-liter oxygen via NRBM was given, and SpO2 comes out to be 89% at that time. On circulation assessment, your pulse rate was 150 per minute. That means patient was in tachycardia because normal pulse rate is between 60 to 100 per minute. BP was normal. Sensorium was GCS score was 3/15. E1, V1, M1 sensorium was unconscious. There was no response in eye movement, verbal response and motor response. So on arrival he was intubated. Indications or intubation were low GSCS, airway protection, sepsis and septic shock. There was difficult airway due to very poor oral hygiene and restricted mouth opening. Pre-oxygenation was done, induction with injection midazolam 3 mg plus again 3 mg. Patient was intubated with 7 mm ET tube fixed at 23 with video laryngoscope. Position confirmed by 5-point auscultation. The 5-point auscultation is this one mnemonic that is known as APE to man. APE2MAN. A stands for aortic, P stands for pulmonary, E stands for Erb's point, 2 man, T stands for tricuspid and man, M stands for your mitral. O से कुछ नहीं है और AN से कुछ नहीं है. तो ऐसे करके we can learn the 5 points of auscultation. There was bilateral ear entry present. Past history of the patient: he was admitted in neurocare hospital with complaint of weakness of bilateral lower limb and an episode of vomiting and hiccup. Condition got deteriorated there, and patient was not able to talk and respond to command. He was on treatment in same hospital from 24 to 25th October. Patient is known case of hypertension and old CVA, that is cerebrovascular accident. He was on regular treatment. Personal history: he was chronic smoker. As said, patient arrived in ER at 9:40 p.m. Intubated there, monitored overnight there, and he was shifted to ICU in the morning at 7:40 a.m. So till that the diagnosis was hypertension, old CVA, LRTI with stroke, with sepsis, with septic shock, with AKI, with uremia and encephalopathy. So sepsis protocol I have checked. How we say sepsis? We see that SIRs must be present. SIR is systemic inflammatory response syndrome. In that we check 4 things: your respiratory rate, temperature, blood pressure and respiratory rate, temperature, blood pressure and your pulse rate. Yeah. So out of these 4, 3 were present. That means your temperature was 103 degrees Celsius on arrival, pulse rate was 105 per minute and respiratory rate was 24 per minute. Now there was infection also. How I have seen the infection: your TLC count was 22,500 cmm. That means sepsis is present because 2 SIRs positive plus infection indicates sepsis. Further, when he got admitted in ICU, he became hypotensive. So severe sepsis is also there because sepsis plus hypotension. My dear friends, lactate is also seen when we see severe sepsis, but lactate levels were normal in this case. And then we say septic shock, that means that was also present because there were signs of end organ damage. There was deranged KFT. That means AKI is present. And further, on CCT scan they showed hypertensive bleeds, acute infarcts in brain and FZAKS1 white matter ischemic changes were present. So till now we have made the diagnosis of septic shock with proper points. Now on the same day, when I seen the X-ray of the patient, there was left-sided pleural effusion. On ultrasound there were ascites and LFT was deranged. There was serum transaminitis. How we see the serum transaminitis? SGOT and SGPT are enzymes, and if they are raised, that means serum transaminitis is present. The normal range of these enzymes lies till less than 40. There was increased level of alkaline phosphatase, there was hypoalbuminemia. Further, KFT was also deranged because there was increase in urea, creatinine, and hypokalemia was also there. Culture and sensitivity of ETT secretions. Report shows the growth of Acetobacter species after 48 hours of intubation. Further management which was given to the patient was injection PAN, which is proton pump inhibitor used for GERD, injection Levipil, which is the treatment for seizures, injection Optineuron, which is vitamin B12 injection Lasix, which increases urine output, injections Aldactone, which is the treatment of high blood pressure, edema and low potassium, injection Chlorophenicol, which is treatment of superficial eye infections such as bacterial conjunctivitis, injection magnesium sulfate, which is treatment for constipation, tetracycline, which is a treatment for bacterial infections, injection KCl 60 ml equivalent at 10 ml per hour, which is treatment for hypokalemia. Further, when I have seen the ECG of this patient, there was ST flattening, and further there was U wave, which is seen in hypokalemia. And इसका जो potassium था वो 2.3 मिली equivalents per liter था. The next day, the situation of the patient. CBC report shows anemia and leukocytosis. KFT report shows increase in urea, electrolytes were normal. LFT picture shows hyperuricemia, serum transaminitis, hypoalbuminemia and increased alkaline phosphatase. Now the next day the complaints were, there was increase in temperature, that was 100.6 degree Fahrenheit. RBS was 164 mg per dl. BP was quite low, it was 91.56 and it was on NORAD support. Urine output was decreased. On chest x-ray there was blunting of CP angles showing pleural effusion. So the management which was given on the very next day, some change was there, that was injection epitoin which was added for seizures. Now they were suspecting hypoglycemic encephalopathy in this case. How hypoglycemic encephalopathy? First of all, I would like to tell you the definition of hypoglycemic encephalopathy. Hypoglycemic encephalopathy is defined as coma and blood glucose level should be less than 50 mg per dl on admission. This is the first condition. Second condition is persistence of coma for more than 24 hours despite normalization of the blood glucose levels. So on arrival, this patient has RBS of 103 mg per dl. The first condition subsides. Now second condition, persistence of the coma despite blood glucose levels becomes normal. So that was present. That means septic shock was present in that patient. GCS was 3/15. Now what are the causes of hypoglycemic encephalopathy? First cause is sepsis, present in our patient. Second cause is alcoholism, present in our patient. Third cause is liver and kidney failure, present in our patient. How? Because there was AKI, there was ALI. Fourth, drugs. He was on drugs, means medications. Now symptoms which was present in the patient, symptoms which are present in the patient of hypoglycemic encephalopathy was also present in the patient, which I am telling you right now. So first symptom is sweating and diaphoresis. It was present in our patient. Tachycardia, present. He came to ER with pulse rate of 150 per minute. Anxiety, present in our patient. Now parts of brain damaged in hypoglycemia are cerebellum and pons, and our CCT report tells us that there is some problem in pons. Like I have told you that when I was reading the case, they have told CCT scan mein there are acute infarcts in brain. So there is abnormality which is found in pons. Now complication for hypoglycemia is seizures, which are the late symptoms which are present in the patient, and drug phenytoin was given to the patient, which comes with the brand name of epitoin. Yeah. Now what happens if blood glucose levels falls more? Like in our patient it was not there, but generally I am telling you, if it is less than 45, brain uses internal substrates such as glutamate and TC cycle intermediates as fuels for ATP production. If it is between 45 to 36, EEG shows no changes. Symptoms increases due to decreased synthesis of neurotransmitters. If it is less than 18, EEG shows isoelectric. Neuronal cell death ensures that may be caused by glutamate excitotoxicity. Now what is glutamate excitotoxicity? Excitotoxicity means a pathological process by which nerve cells are damaged and killed by glutamate. Receptors for glutamate, that is NMDA, AMPA, they are overstimulated or overactivated. Excessive stimulation or excessive excitation of glutamate receptors have been associated with hypoglycemia and stroke. Cases in which there is lack of glucose, oxygen ending in the lack of energy production in CNS. So that's all. There was kick while studying this patient. Why? Because hypoglycemic encephalopathy was something new to learn, and I really enjoyed learning on this case. I hope you also got to know some new points if you were patient till the end listening to the history. So yeah, Dr. Muskaan is signing off now.